Hey guys, so here we go. Topic will be addiction. I think first we'll start by just defining addiction. And the definition that I have wrote down is addiction is a compulsive and maladaptive dependence on a substance or a behavior. The dependence typically produces adverse psychologic, physical, economic, social, or legal ramifications. So, just to define a minute, we talk about this compulsive or maladaptive dependence on a substance. So, by substance, we're talking about things maybe such as alcohol, cocaine, tobacco. And then these behaviors that we're talking about when we say a compulsive or maladaptive behavior, we're thinking gambling, pornography, that sort of thing. So that just kind of defines it so that we're all on the same page as far as what we're talking about as far as an addiction. So, some other key terms, just as a quick review substance abuse. Substance abuse I have wrote down here as an overindulgence in or dependence on a substance. Dependence, patient is dependent on a substance and withdrawal occurs. So if we take that substance away, then we notice withdrawal. Tolerance, this is the capacity to endure. So tolerance sometimes, if the patient is a drinker when they first start drinking, it may take one or two drinks to cause the feeling that they're looking to have. Where later down the road, once their tolerance is built up, once their capacity to endure the alcohol is built up, it takes more drinks to do this to have the same effect. And then the last term is withdrawal. And that's when the substance is taken away, or the behavior, as we talked earlier. So, how do the terms relate to the concept of addiction, these terms? Just something for you to think about. So, as far as a scope of addiction, you can kind of think of addiction in this bubble, and then there are two connective bubbles that go with that. And one is substance addictions, and then the other is behavior addictions. So we have addiction, and then off from that, we think of the substance addiction and behavior addictions. Neurotransmitters that are involved in the reward system play a big role with the physiologic process of addiction. So I just wanted to talk real quickly about some of these neurotransmitters. And one is dopamine. And with dopamine, we think of it because it contributes to a feeling of pleasure. And then we have the GABA, GABA. And that neurotransmitter is focused on anxiety and mood. Glutamate, it is the most abundant excitatory neurotransmitter. Acetylcholine, that regulates the sleep and activates pain response. Norepinephrine, you guys know what norepinephrine does, but it helps to mobilize the brain and body for action. And what is that one action that we think of? That one thing we think of when we think about the norepinephrine? Fight or flight. And then we have serotonin, and that's a contributor to feelings of well-being and happiness. So just defining those, and just as you're hearing me talk about those specific neurotransmitters, and the idea that I'm telling you that those are kind of involved in that physiological process of addiction, can you understand why, with knowing what those neurotransmitters do and what they're responsible for? You know, we're talking about feelings of pleasure, our pain response, the feelings of well-being and happiness. So those all tie together with addiction. So consequences of addiction, most of the time we can see these. The problem is a lot of times when the patient is addicted to something, the patient doesn't see the consequences. They aren't able to see past that instant gratification of the behavior or of the substance that they're with. So the family is the one that a lot of times suffers and is sitting back watching the consequences happen to the patient and their family. So anyway, consequences are dependent on the individual and the type of addiction. So consequences may include adaptation, tolerance, withdrawal, and we kind of have already talked about those. I just do have a little keynote here. Tolerance is you maybe need one drink at first to produce a calming effect or get that feeling that you're seeking. Later, you're going to need more and more and more to produce that same effect. So that's tolerance. Withdrawal, we talked about, that's when we're taking away that substance or we're taking away that behavior. Identifying addiction. Problems in areas of life function. It may be legal, financial, social, marital, occupational. Reported leisure activities involve alcohol or other drugs. So these are things that I want you to think about if you're taking the patient's history. If they've had a problem in the legal aspect of something going on in their life, or if their finances are not in order and they've had troubles there. Those are kind of warning signs, things that that needs to set off those red flags. Driving while intoxicated, if they report a history of that. Reported injury associated with falls, fights, automobile crashes, and so on. Substance abusers often are hesitant to disclose information about addiction. One, a lot of these patients don't think they have a problem. They don't think they have an addiction. So, of course, they're not going to foreclose that information because they don't think there is a problem. I want to talk just real quick about the CAGE questionnaire. This is an acronym, the CAGE. And what it is an acronym of 4 questions. And it's a screening test for problem drinking. So this is one way, one thing that we can use to assess a patient to find out, do we think they have a drinking problem? Or, maybe are we jumping the gun? So the questions. Number 1, have you ever felt you need to cut down on your drinking? And the cut down on your drinking, that C represents the C in our acronym. Number 2, have people annoyed you by criticizing your drinking? The annoyed is where we get our A for that CAGE. C, so the C is our cut, and the A is our annoyed. Number 3, have you felt guilty about drinking? The G in guilty is our G. So we have our C-A-G. Our last question, have you ever felt you need a drink first thing in the morning as an eye opener? So that E on eye opener makes our E for our CAGE. So we have our C. We're asking, have you ever felt like you needed to cut down on your drinking? We have our A. Have people been annoyed? Or have people annoyed you by criticizing your drinking? That's our A. G is guilty. Have you ever felt guilty about drinking? And then number 4 again is our E. Do you need that drink as an eye opener in the morning? If the patient answers yes to 2 or more questions, that indicates the possibility of alcoholism. Common addiction symptoms. So I'm going to list some off here, and then we're going to talk about some specific substance addictions. So some common addiction symptoms. The patient may complain of fatigue, insomnia, headaches, anorexia. They may have a reported sexual dysfunction. I'll have to not let Taylin listen to this lecture, or that will be the one thing she'll pick out. They may report change in mood, weight loss. And they may also just present and complain with vague physical complaints. So, clinical manifestations of an opiate overdose would include a seizure, shock, respiratory depression, dysrhythmias, and an altered level of consciousness. So when I'm saying these opiates, what I'm thinking and what I'm talking about are drugs such as heroin, morphine, oxy, hydrocodone. Those are the things that I'm wanting you to think along the lines of when you think about an opiate overdose or opiate use. What would be a priority nursing assessment for a patient who has had an opiate overdose? It's going to be a respiratory assessment. And why? Because if the patient overdoses on opiates, these opiates, they depress the respiratory system. So if we're not breathing, that's a problem. The respiratory assessment is going to be critical in any patient that we feel has had an opiate overdose. Another thing I just wanted to talk briefly about, let me make sure I've got everything about the opiates because I kind of have it wrote on two different pages here. No, let me go ahead. So symptoms of opiate withdrawal. These symptoms are going to be similar to those of alcohol withdrawal. So the patient may experience nausea, vomiting, diaphoresis, which means what? If you don't know, look it up. Anxiety. And I already told you the opiates, they are central nervous system depressants. So they're going to depress things. They're going to depress the respirations. We may see a decreased blood pressure. We may see a decreased pulse, slurred, slow speech, drowsiness. Those are all things that we can expect to see, especially when first injected. All right. Now, another substance that patients tend to use and abuse are amphetamines. If the patient was coming in with an amphetamine overdose, you're going to be thinking hypertension and central nervous system disturbances such as paranoia, panic, delusions. We always want to think with any of our patients that may be coming in with a questionable overdose is safety. We have to be thinking, and we always want to think about those ABCs. So anytime you would have a question regarding that, you want to be thinking airway, breathing, circulation. Because as I've just told you, some of these medications, they already suppress these systems. And if we're already suppressing them with a normal dose, when we overdose, it's getting a major whammy and really suppressing things. So I just wanted to mention too, another thing that is common for people to use and abuse and even overdose on, especially our teenagers, are bath salts. So if we have a patient that comes in and we're caring for a patient who has used bath salts, some things that we may notice would be tachycardia, chest pain. They may have very bizarre behaviors and paranoia. Defining characteristics of addiction. It is beneficial to use motivational interviewing to identify defining characteristics of addiction. These characteristics may include tolerance and withdrawal, deception of self and others, and relapse. The nurse should always show compassion, be caring and helpful for all patients. I'm not a big one with this addiction. I really have to stop and kind of self-reflect and get my thoughts together regarding this, because I really have mixed feelings about it. This is kind of one of those things that I feel is very self-inflicted, and it just, I have a hard time with it. So I know I'm not the only one that has a hard time with it. So it's just one of those things where, as a nurse, you really have to kind of self-reflect and self-assess and get our personal attitudes in check and in line before we ever open the door to go in that patient's room to provide care to the patient. We have to show compassion. We have to be helpful. We have to offer care to these patients, regardless of what they're there for, whether it's something that they have self-inflicted or not, whether it's something that our morals and values go completely against or not. We have to make sure we keep a wrap on that. Recognizing withdrawal is important. Patients have a difficult time when they're coming off of these substances that they've become dependent to. Alcohol withdrawal, if you have a patient with alcohol withdrawal, you may notice an elevated pulse and blood pressure. There is a thing, withdrawal delirium, and symptoms would include agitation, perceptual distortions, along with those vital changes that I just discussed, that elevated pulse and blood pressure. So patients, I talked a little earlier about the denial and how, sometimes I think that that's just because they don't see that they have a problem. Other times it's because they know they have a problem, but they're going to deny it because they don't want you to think they have a problem. So patients in denial will minimize their drinking. So they may say, well, I only drink socially, or I only have a drink every now and then. When in reality, that's probably not true. They may have answered 2 or more yeses to that CAGE questionnaire we talked about, and they may drink like a fish. Patients in withdrawal are at risk for injury, and that mainly comes from that perceptual distortion. So remember back when I talked about the withdrawal delirium, I said the symptoms could include agitation, perceptual distortions, along with the changes in vitals that we know, that elevated pulse and elevated blood pressure. But these patients, they are at risk for injury. So these would be patients that we wouldn't want to leave alone. We would want to make sure we have eyes on them to make sure things are okay with them, and not leave them alone. If you have a patient diagnosed with an abuse disorder, become agitated, fearful, hallucinations, one-on-one supervision is necessary. We don't leave the patient. Alcohol abuse, when we have someone that we know is abusing alcohol, sedation often allows for safe withdrawal. So sometimes we use the benzodiazepines. Those are often our drug of choice. And the reason they are is because they have a high therapeutic safety index, so they're fairly safe for us to use. And they also have an anticonvulsant property to them. So when these patients are withdrawing, it's not uncommon for them to have convulsions because their body is so used to, so tolerant to this substance that has been continually exposed to it, that when they no longer have it, the body kind of doesn't know how to react. So the benzodiazepines, Ativan and Librium, are 2 common ones that are often used. So when we're thinking about care with our addiction patients, we need to be sure to always consider the interdisciplinary team. So people that we may need to get involved would be the physician, whether that be the PA, the physician's assistant, an MD, or a nurse practitioner. We also need to have the nurse on board, the social worker, and the counselor or psychologist. So there's this thing called Antabuse, And this is something that is useful to help treat alcohol abuse. This medication causes an acute sensitivity to alcohol. So some patient teaching things that we would need to think about. They would need to avoid alcohol in any source. So as far as patient teaching, this would include that the patient would need to be alert to any alcohol in cough medications that they maybe have. Alcohol is also in aftershave and in cologne. So any alcohol that the patient may come in contact with, they need to be paying attention to this, because if they are taking this antabuse and they come in contact with them, the aftershave or the cough medication or the cologne or whatever it is that has alcohol in it, whether it comes in contact and is absorbed through their skin or they take it like they would the cough medicine, PO, they are going to get sick. And it's going to be a bad sick. Delirium tremens, that is abbreviated DT. This is a psychotic condition typical of withdrawal in chronic alcoholics. It involves tremors, hallucinations, anxiety, disorientation. Some other things that these patients may experience are nightmares. They may have abdominal pain. They may have nausea, diaphoresis. These patients, we may notice there's some changes in their vitals with an elevated temp, an elevated pulse, an elevated blood pressure. And then I already said the hallucinations, but those hallucinations can be visual or they can be auditory. For clinical management, as far as a collaborative intervention, we have emergency management, which the goal there is to prevent life-threatening complications. Treatment is substance and complication specific. We talk a lot about how things are specific based on what we're treating, and that's important to remember, because that's going to follow you throughout your nursing career. And then we also have, with collaborative interventions, we have recovery. And the goal there is to help the patient to get the help needed to achieve and maintain sobriety. So stay clean. We want them to get the help they need to stay clean. Collaborative care is used to facilitate success in recovery, and this includes motivational interviewing from the nurse. And then during that recovery phase, it's important to remember and to understand that relapses are common. As much as we try to prevent them, relapses are common. We want to encourage the patient as best we can, but 8 out of 10 are going to relapse, and they're going to fall back into that cycle. It's a hard cycle to break. All right. So if we have a patient brought in the ER with a respiratory rate of 8 breaths a minute, and we notice cardiac dysrhythmias, we're going to be thinking, maybe this is a drug overdose. And it's important and it's critical to ask the patient. Patients aren't always honest with us, but we need to give them that chance. We need to give them the opportunity to tell us if they have taken something, injected something, snorted something, whatever 50 different ways people can do drugs. We need to make sure we give them the opportunity to explain to us what they've done. And that helps us. If they will open up and tell us, that helps us. Priority outcome for these patients would be to see the vitals to begin to become back to normal, return to that normal state. Now, are we going to notice a real quick change? No. The vitals need to come back to baseline or come back to normal, kind of in a slow and steady pattern. They're not going to necessarily jump by leaps and bounds as far as returning to normal. When a patient's beginning treatment for addiction, the nurse needs to show support and empathy. This allows the patient to feel safe enough that he or she can start looking at problems and identifying their problems. They also are able to speak open and honest when they've developed that rapport with the nurse. And counseling for these patients needs to be direct. It needs to be honest. It needs to be open, kind of right to the point. So some recommendations for patients with addiction. We would want to consider family intervention. That may be family therapy. The patient also may need cognitive and behavioral therapy. We can offer group therapy. Peer support is a wonderful, wonderful thing sometimes. And rehab services. Sometimes the patients, depending on their situation, they may need rehab services as well. All right, guys, so that was the short and quick of addiction. If you have any questions, please do not hesitate to reach out to me. I will open a discussion on under the assignment column, and if you have questions, by all means, go ahead and put them there. Make sure you put, if you do send me a question, addiction, and then write the question so that your classmates, when they go to look at it, if addiction is something that they were having questions on, they can pull those and kind of look to see if their question's already been asked. All right, that will wrap it up. Thank you, guys.